Hello, my friends. My name is Dr. Ruiz, and I'm the director of the LA Institute, and very excited to share adhesive magic with you here on dentistry today. Today, we're in charge of talking about minimally invasive bonded bridges, and specifically about the anterior situations where we have a missing tooth that cannot be replaced with an implant, ideally. So what do? So bonded bridges to the rescue. This is a very, very cool procedure. And we're talking about minimally invasive because if we needed a medical procedure, we want minimally invasive. And realistically, dentistry should be the same. If we have a badly broken down tooth or a difficult situation, minimal invasive should be the choice. Unfortunately, that is not the case. We know that 98% of all indirect restorations are crowns in the US, which is pretty much the same around the world. And it has a lot of collateral damage. Prepping a tooth too much, grinding too much, traumatizes the pulp. We know this, research shows that. Every time we put margins below the gums, we know that we irritate the gums and we cause some damage as well there. So all of this is in my book, which is very, very popular by Wiley. But let's focus on a missing tooth, right? When you see a missing tooth, what's the first thing to come into mind? Implant, right? And of course, implants are awesome when you have enough bone. We have healthy gums. But what if we don't? Sometimes we try to force an implant on a patient that doesn't have sufficient bone, and we do this complicated, expensive bone grafting procedures. And I've referred patients for this type of procedures many times, and they're tough and they're expensive and they're painful. Sometimes they don't work the first time, and you need to do a second surgery. And the worst part is that they don't work as well. Artificial bone is not as good as the real thing, and research is clear that they fail at a pretty high percentage compared to when you have healthy bone. And then in Sweden they have very good studies showing that all implants altogether at 9 years, research, beautiful research done on all the population over there, shows that at 9 years, 10% already failed regular implants. So implants have problems. I don't want to get too deep into that, but implants have problems. And when we try to force an implant, in certain cases, this is what happens. This is a young patient referred by a periodontist. The implant failed and unfortunately damaged the adjacent tooth. And now what do? This is a young actor who doesn't want to walk around with a stapler forever. So what do? And we fortunately we live in a time where adhesive dentistry has a lot of solutions. And thanks to research by Dr. Matthias Kern, we understand that a cantilever bonded bridge is actually a very good choice. And in fact, based on his research, it will outlast an implant. It will be more successful than an implant. His research shows at 10 years, 100% success. I've been doing it for about 7. I placed like 3 dozen of these ones. There's only one that has fallen off, and I had to re-cement it. And it was a football player who got hit. So they work, friends. They work. The preparation is not very difficult at all. A number 2 round burr. And what we recommend in our hands-on workshops, this video comes from one of our hands-on workshops, is to draw the outline, because it's very important to ensure for success, to ensure that we have sufficient connector size and sufficient retentive pad size. The connector should be no less than 2 in width and 3 in height, and the retentive pad or wing should be approximately 30 millimeters square, which is about 5 by 6, and it has to be a minimum thickness of 7 millimeters. The porcelain needs to be a minimum thickness of 7.7 of a millimeter. So we use our round burr, which is part of our LA Institute kit. You can buy it from Brasler, but this is really just a simple number 2 burr. number 2 round. And by the way, a number 2 round, if you measure it, is a millimeter in diameter. So if we sink it only partially, it will allow us to get to about 0.7, right? We have tested that if we angle the burr at 45 degrees, the shank will stop us at 0.7 millimeters in depth. So if you sink it fully, again, it's 1 millimeter. So after we draw the ideal outline, then we use the burr, the round burr, to create the depth cut and to establish the outline. And as you can see right there, this is something that we do again. This is one of the multiple exercises that we do at a hands-on workshop. And as you can see, it's not very difficult at all. The number 2 burr is the perfect instrument to do this. Once we establish the outline, then we start doing the depth cuts. And the depth cuts are basically horizontal lines that will allow us to also establish the depth. So right there, because we have everything drawn, we know exactly where to go. And by the way, I do this in the mouth too, friends. I draw it in the mouth initially just to get a little feeling of how far I can go facially. And it just makes it more accurate when you're doing something like this. So then we do the depth cuts again at 45 degree, sinking it. So it gives us about 0.7 millimeters of depth. Believe it or not, it doesn't require any anesthesia because we're pretty much on enamel. So when I do this, I don't anesthetize my patients, and they don't have any pain. And by the way, I don't temporize them either because most of these patients are already on state plates, so we don't need to provisionalize. After I do my depth cuts, I will draw with a very sharp pencil. So I draw the base of that depth cut, and then using a large burr, in this case, I use the same burr that I use for my occlusal reduction. It's a 2 millimeter at the tip. So it's very easy to just join the depth cuts and get to the right depth. Basically erase everything until the pencil marks disappear. And as we do this, then we get the correct depth. Now let's remember that if the patient doesn't have contact in the area, we may even need to prep less. I always establish outline, even if I don't have to prep much. I don't like it to be bulky in the back, so generally I always prep at least a little bit. Again, if I have a lot of space, I might not go to the full 0.7 of depth, but I will do some reduction. The minimum depth of the porcelain does have to be 0.7 of a millimeter. It is desirable to create football shape indentation right on that line angle, on the proximal lingual line angle. And the purpose of that is to actually reinforce the connector. And it also gives us a little bit of an ideal insertion, so it doesn't move. And that's very important during cementation. Cementation is very, very simple. Dr. Ray Bertolotti and myself have written an article also on Dentistry Today, in which we talk about this type of bridges, but also other bridges, because we have missing teeth in the mouth and a variety of different circumstances. And so I do bonded bridges sometimes when I'm doing veneers and I have a missing tooth. I will use the veneer as a retainer. This is an example in which I did exactly that. And sometimes I do posterior bonded bridges, and the design is also a very simple. There's a variety of designs that we can use to retain our posterior bonded bridges, and of course, it's very important that we're minimally invasive. So as you can see, the preparations tend to be always only on enamel, very rarely get into dentin. Very important to use the right zirconia. You want to use the maximum strength zirconia. Don't use translucent zirconia. Remember, zirconias can be of all kinds of qualities. So for that reason, I tend to ask for katana zirconia, which is the one that has the most research and best quality. And just to end quickly, I recommend that when you're thinking about bonding to zirconia, that you read this article by Marcos Blas and Marcela Alvarez and other colleagues. They simplify the understanding on how to bond to zirconia. They call it the APC of cementation. A is for air abrade, P is for prime, and prime has to be MVP based. Lots of research on this, and this material happens to be a corrosive material called ceramic primer. And the cement can really be using this technique, can be any resin cement of your choice. So remember that bonding to zirconia is very, very predictable. I invite you to visit us in Los Angeles on our workshop center, which is state of the art. And if you're interested in bonded bridges, my gosh, we have a 2-day workshop that is phenomenal. We prep multiple designs for multiple situations. And of course, it is really a pleasure. I hope you have a wonderful day.